Needed to update everything. All right, can you all see that okay? No? Yes? No?
Yes.
Okay, perfect. Okay, so I'm just going to read it to you. Jamie Carson is an 18-year-old male with a history of nausea and vomiting and periumbilical abdominal pain. So, okay, where's periumbilical? In your assessment, where is that at? You can point to your stomach or tell me what that word means.
Around the belly button area.
Around the belly button area. Okay. So he's had the periumbilical pain and the nausea and vomiting for the past 24 hours. His primary care physician referred him to the emergency department where he was diagnosed with acute appendicitis. An appendectomy was scheduled. So Jamie is admitted to U on the med-surg unit with classic signs and symptoms of appendicitis. His admission history was completed, and during which Mr. Carson described initial pain as cramping over the periumbilical region that gradually localized to the right lower quadrant and became quite sharp. He reports nausea and one episode of vomiting, but no diarrhea, sick contacts, or recent trauma. So that's kind of your story, right? So keep all of those things in your mind. Okay, so then you're going to go start case study. Okay, so now you have this patient yourself. So you're going, is this how your guys' looked? I'd put it in student view. So hopefully this is how yours looks, right? Okay, I just want to make sure. Okay, so you need to review their history. Okay, systems assessment, vital signs, that's all right here. Okay, so you go into his room. He's in Fowler's position with his knees drawn up and arms guarding his abdomen. What's that telling you? If you walk in and somebody's kind of in the fetal position, what could you assume is going on?
He's having pain.
Right. Okay. So just think of you're this nurse, you're walking in, and this is what you're seeing. You're seeing him, knees drawn up, arms guarded. He's holding his belly. Okay. He's saying he has an 8 out of 10 pain. It's a constant pain. Certain positions make it worse, while some make it better. Okay. He's breathing rapid and shallow and appears anxious. Okay. You're looking at his skin. He's slightly diaphoretic. He's somewhat pale. Okay. He's hot, nauseated. Okay. The abdomen. So you're doing your belly x-ray now, or your belly assessment now, not your x-ray. You can't do x-ray with your eyeballs. Okay. So you're looking at his belly. It's rigid. Okay. What does a rigid belly look like? Has anyone ever seen one on a patient? No. Okay. It's hard. Okay. Looks really firm.
A
It's
board
hard.
like.
Yep. Board like. Yep. So you look at it, you can tell it's like, their muscles are really tense and hard. Okay. And you go to push on his belly with light palpation. What's deep palpation? You're looking, if you're palpating deep, what are you trying to feel? Like if you push deep, usually you're looking for like a mass, right? Okay, that's kind of what your goal is for pushing deep. With light palpation, it's just kind of more like pain, right? You're checking their pain and all of that. Okay, so with light palpation, the left lower quadrant of the left lower quadrant. So you're pushing on the left lower quadrant and he's having pain that goes to the right lower quadrant. Okay. The belly's flat, so it's not distended, it's not round. Okay. So think about that was your assessment. Okay, your vital signs. Here are their current readings. So he has a fever, right? What else is going on with his vital signs? Are 22 respers in a minute for an 18-year-old? What's up with that? Is that okay, or is that a little quick?
It's rapid.
Yep. Okay. What about a pulse of 102?
It's elevated.
Yep. A little elevated too. What about his blood pressure? Is that blood pressure okay for an 18-year-old? Or do you think it's a little high?
Slightly higher than typical.
It's a little high. Yep. Good. And his oxygen, that looks okay, right? 97. That's okay. Okay. So what are those all telling you? They're all elevated slightly. What could you assume based off of his vital signs and with how he's looking?
Patient is in pain.
I think the pain is causing the elevation.
Yep. Yep. And the fever, right? From the inflammation and of the appendix and the infection. Okay, good. So then you're gonna go and document. Okay. And then you guys should click. So you have to document your system assessment, GI, and your pain assessment charts. Okay. So we're going to go to start phase. Okay. So in here, you're going to have to kind of navigate, right? You're going to have to figure out where everything's at with these. So your summary, that's going to have your vital signs. You can click through here, your pulse. So as you go, that, your vitals would be trending here just like they would be in a usual chart. Okay. Your patient card. This is going to be kind of general information. Okay. Your orders are all going to be here. Okay. Your provider charts are going to be in here too. So just clicking through and looking at all of this is going to be really helpful. It's not really filled out in this one. Okay. And then, okay, so you can look at your orders, and then as you scroll down over here, patient data, allergies, all of that is within there. Okay. So you're going to go here. Your patient charting is going to be where you need to go, right? Because we're supposed to be charting. And also, I don't know, do you guys have this little button here, assignment information? Are you guys going along with me right now on your side? Okay. So you have this assignment information. If you click that, that will pull up, okay, here's all of here's how your patient was looking. Okay. So you can look at that while you also chart your stuff. So you don't have to try and remember all of your assessment. Okay. Okay. So we're going to go in here. We're going to go into our assessment. Okay. So we're going to do GI assessment. Okay. We pull the information up. Okay. We need to, did you do an esophageal assessment? There's nothing in there in your story, right, about the esophagus, right? So you just leave that. You don't note that. Now, the abdomen. What should we add here? In looking back, okay, let's see. I'll click back over here and we'll scroll down a little bit. I couldn't hear whoever unmuted for a second.
Rigid.
Rigid. Yep, let's add that. Right? Okay. What else? Come on, guys, don't be shy.
Patient was guarded or guarded.
Uh-huh. They're guarding. Okay.
It also said flat as well.
Yep. What else? Up here, are you guys chatting me too?
The muscle reaction with light palpitation.
So that was the rigid piece.
Okay.
Yep. Yep. So that's just saying that the muscles are rigid. Yep. And then what about the location? Can you say location here? No, we have to come here, right? Oh. For some
Would you
reason
say tender to light palpitation and then put in where it was?
yes. Yep. Yep. So you can add that in there. I wonder if because you guys are in it with me, if it won't let me.
No,
some
you have to add in tender to light palpation, then it'll let you.
Oh yeah, there we go. Tender. There we go. Sorry. There we go. Now we can do it. Okay, so periumbilical, right? What else? What else is in there?
It radiates to the right lower quadrant.
Mm-hmm. Okay. Let's see over here for GI problems. What can we add in this section? Remember our overview, right?
Nausea and vomiting.
Yep, good. What else can we add here? Cramping, abdominal pain, right? Because he talked about in this constant. Oh wait, here, it was in the initial one. Cramping, right? So you can use that. What else? Yeah, so it won't let you pick. So for some reason, it won't let you pick more than, or for me at least, it won't let me pick more than one area of tenderness.
It won't me neither.
Okay. So then I would just go here, right? Or you could do like generalize, since it's multiple areas. It's periumbilical, it's right lower, it's left lower. So you could add here right lower. Right. Pain. Palpation of left lower. Okay. Does it tell us anywhere about their bowel movement? We don't know anything about that, right? No. Don't have any sort of information about that. About their bowel sounds. We don't really have any information about that either, do we? Okay. Okay. All right. Now let's go to oh, I have to save it. Where's my save button at? Now that it.
Our save button is at the bottom, but I don't see it with yours.
Yeah, I think it's just because I'm in student view. Okay, but you guys have the ability to save it. So I'm just gonna go back then, so that way we can do the pain
Yes,
assessment.
ma'am.
So let's go to the pain assessment part. Did you guys know that you could pull up your assignment information and look at that while you were doing your assessment and things?
Yes.
You were aware of that. Okay. Because I know some other students were saying that they weren't aware of that. So that definitely helps, because if I had to try and remember all of those things by memory, that would be very difficult. So, okay. So looking at the pain, is he in pain now when you're doing your assessment? Yes, he's saying he's in pain. What sort of pain is he saying he has? Constant, intermittent? What does he say over here? He's
Constant.
saying constant. Yeah. Okay. Oh. Where's his location of his pain? Okay, now you can be really specific here, right? Anyone want to tell me? Right? Periumbilical. Where else?
It's the right lower quadrant.
Mm-hmm. Okay. Okay. Oops. Helps if I can spell correctly. Okay, what's his pain intensity on his pain scale?
8 out of 10.
Right. Okay. What are his nonverbal cues of pain? What are some nonverbal things in his presentation?
Guarding.
Yep.
The fetal position.
Yeah, the positioning. I think that's an option too. Nope. What about
He's diaphoretic, shallow breathing.
yeah, what else? Anxious? Right? Yeah, it doesn't say anything about grimacing or wincing or anything like that, but it said anxiety and guarding. The diaphoretic and the shallow rapid breathing would be more physiological versus behavioral or psychological, okay? Because those are your body's changes, not your nonverbal kind of cues, okay? So he has increased cues of pain. Let's look back at his vital signs. We kind of already talked about this. Little tachycardic, little tachypnic, right? Breathing a little quick. We didn't look at his pupils, but he's also having diaphoresis, right? He's diaphoretic. Okay. What about the quality of pain?
Like cramping.
Yep, that's what he said originally, right? He hasn't changed the story on that. Did anyone else add anything else with that? Okay, what's our aggravating factors? What worsens his pain?
Positioning.
Positioning, yep. What goes along with positioning? Movement, right? Here, I'm gonna scroll down for you guys. Oops. Okay, good. What makes it better?
Changing position.
Yep, positioning. Right? He said some positions make it worse, some positions make it better. Okay. Good. Okay, so you guys can save that, right? So you've done both of those. So then you can mark that as complete. So let's mark that as done. Okay. Oh, then it's going to tell me your guys' quiz answers. So I'm not going to show you that part. But that's how you do the first portion. Okay. Let me go back to. Hang on, I'm going to stop my screen share because I don't want to give you guys the quiz answers because that part you need to do on your own. Okay. But that's how you're going to kind of navigate it. Make sure you're doing that before you jump to the quiz. Okay, let me get back here and then. Okay, sorry, it's taking forever to get back here. Okay. So we did the first part. Let me click to, I'm going to click to phase 2, okay? But I don't want you guys to be able to see the quiz answers, so we'll just click through here. So in a patient with appendicitis, how do you feel like their belly is going to sound? Do you think they're going to have really great bowel sounds? Do you think maybe they're going to have some slow bowel sounds?
Hypoactive.
Yep. Good. Okay, now I'm going to share my screen again with you all. Okay, can you see that? For phase 2? Okay, cool. Okay, so phase 2. So now he's back from the PACU, so he's back from having surgery. And during your assessment, now he's drowsy, but he's arousing, okay, and responding appropriately. You're looking at him, his belly is soft, it's rounded, it's tender at the incision sites. That all seems pretty normal, right? After just having surgery. He's reporting intermittent pain, 3 out of 10, with pain described as a dull ache with movement, but tolerable with rest. Opioid medication was given during post-anesthesia in the PACU. Bowel sounds are hypoactive, okay, in all quadrants. Mr. Carson denies nausea. 3 small abdominal incisions have scant dried blood. Here's your vital signs. How are the vital signs looking now after surgery?
Please
Those
improve.
are expected improvement.
Yeah, yep, they're trending in the right direction, okay? Good. All right, so now you're going to go and you're going to document your GI and pain assessments again, okay? So now for you guys, it will have saved, but for me, it will not have saved. So let's go to GI. And we're pulling him back up now. Okay. So how is your assessment looking now? What should we say about his abdomen? Is it hard or is it soft?
Soft and rounded.
Soft, round. What else though?
Tender at the incision site.
Tender. Yeah. So you could put tender and then, well, it's not going to let you put incision site here. So then over here, you can put tender at incision site. Okay. And then what about here? Do we need to add anything here? He's not nauseated any longer. Okay. That's all okay, right? What about his bowel sounds? What should we put here? Hypoactive, right? Oh. Okay, guys, be careful while you're clicking through this because it'll change. You don't click out of it, or at least that's how mine is. It's not having any diarrhea or anything still, so we don't need to add any of that. Okay, so that's your assessment. Do you think that there's anything else we should add to your abdominal assessment? No? Okay. All right, let's go to then your pain assessment. Okay. So is he having pain now? Still having pain?
3
Yes.
10. 3
Yeah.
out.
Yep. And is it constant, intermittent?
Intermittent.
Intermittent now. Yep. Where's the location of his pain? Where's his pain now?
At the incision site?
At the incision sites. Good. And he's rating it out of 3. Somebody already said. Okay. What are his nonverbal cues this time? Is he having nonverbal cues this time, do you think? Doesn't talk about any nonverbal cues this time, does it? He's not tachycardic, right? He's not tachypnic any longer. And it's not saying anything about being diphoretic, right? So that's all improved as well. But let's talk about the quality of pain because that's changed too.
It's dull and aching.
Uh-huh. Okay. Okay. So what makes it worse?
Movement.
Mm-hmm. What makes it better?
Rest.
Uh-huh. And then what else did he get that could have helped?
Opioids.
Narcotic
Medication.
medication.
Yeah. Yep. Good. Okay, so then you can save that, correct? And that's all that we needed to do with that one. I'm going to stop sharing my screen here. Mark it as done. This one seems a lot more, so like your endocrine one that you guys did, that was a lot more cumbersome. This one seems a lot more like appropriate, like nursing things you guys would do as far as charting and things. Do you agree with that? Yeah. So then you go through your quiz and you exit out of that. Is there extra stuff that you guys get on your side that I can't see on my side? It just goes right into then the assessment, right? You don't have any extra like assessment stuff that's filled in, correct? No.
No, we don't.
Okay.
I'm sorry, Dr. Becker. So we do not receive credit for the documentation portion? That's not part of the grade? Am I understanding that correctly?
Yeah, not as far as I'm aware. It's based off of your quiz.
Wow.
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 I've been spending more time focusing on the appropriate documentation,
Well,
assuming that would be beneficial and helpful. But I mean, as far as the learning curve, yes, that is. But
yes.
toward the grade, it doesn't reflect. Correct? I guess.
So you have, let's see, this is you guys still can't see my screen, right? I just want to make sure. I'm going to pull up. Somebody's here. So when we look at it, so it's pulling up everything that you guys clicked on for answers. How long it took you, how long you all spent. So that will all be considered. But as far as the grading portion, it is solely off of the quiz. But like I said, you know, if there's a lot of poor grades and then it's reviewed, that very minimal time where we weren't going through and doing all the things that were required prior to just going in and doing the quiz, that will definitely be looked at and can be looked at. So I understand the frustration of having to go through and do the learning portion of it, of documenting and doing the case study review. But yeah, unfortunately, it's just the quiz piece that is graded.
Now, once you're in the quiz, Dr. Becker, it doesn't let you go back to see the patient information, just what's in the chart, not like how the assignment information is on the side. It doesn't let you see that once you're into the quiz.
Right. It's just based off of your assessment findings, right? What you guys plug in there. Correct?
Yeah, I usually just take a picture of those before. So when I'm charting,
just take a picture. But how is that benefiting us learning if we have to refer back to a picture?
Right.
yeah.
Yeah. No, I think I mean, I don't disagree with you guys. It's a lot and seeming like it's not super beneficial for you all. So I will talk, like I said, with Professor Bogart about community stuff, you guys getting those emails and verifying, I guess, if that is accurate, or if that's just purely because we were shutting off the grades for the homework assignment, like what Victoria brought up, how the grades were changing and on the assignments from your KGA to your non-K to including your non-KGA things. But let's go. Do you guys want to do Kahoots, or do you want to go back to the PowerPoint to do GI material? What do you think?
Kahoot.
Kahoot? Is everyone good with that? Do you feel like going through that was beneficial? Like, are you wanting to maybe, here's the only thing is if I go through like in SimChart, if we go through it together, kind of like that for say next week's class, you guys, if you're doing it with me, you guys probably can't pause prior to doing the quiz, or will let you pause and get out.
No, I just rushed through the quiz just now so I can get to phase 2 to understand how to do phase 2, but it is what it is.
Okay, I'm sorry. I didn't realize that that would happen. So, I guess what we could do for next class is I can navigate it with you guys if you feel like that's helpful, or if you want to just do it on your own, then we can do it that way too. I want to try and make it easier on you guys and not so cumbersome. So as soon as Fallon, as soon as you marked phase 1 complete, is then when it prompted you to do that.
Yes.
Okay, so if you left it unmarked, it doesn't make you go directly into the quiz, correct?
That's correct.
Okay. I would like some feedback from you guys. What are you thinking? Do you think it's beneficial?
I personally don't have a problem with the navigating in the chart. It's just some of the questions doesn't make sense.
The quiz piece is.
The quiz piece of it.
Uh-huh. Well, and in looking at them, it's not always like, unless you've read specific things, like as far as your exam, or it's telling you that specifically, some of the quiz questions aren't.
It's not pertaining to what you just done. Yeah.
What you're doing.
You would have to go back and go through the chart and like look up the information.
Yep.
Yeah.
Yep. Yeah, so I've heard other students who are like taking pictures so that way they can keep the material too. I've heard that from multiple students. But yeah, it's not super it's not seeming as helpful as the CJ Sims were.
No, and everyone's documentation is different. You know, I mean, every hospital, every clinical is different. So I feel like this just isn't beneficial on documentation.
Right. Mm-hmm. Because
I second that.
And we're on week 8, so it's like it's no sense in going back. We need to focus more on like the HESI, the exams.
Right.
I just feel like it's definitely not as beneficial as it would have been in the earlier weeks.
Yeah, I agree.
Yeah. Well, and now we're still learning material too. So then you're still getting the material and then these as well. Yeah, no, I understand. It's all good feedback from you guys. So I'll make sure and let Professor Bogart know, and your guys is feeling like CJ Sims seem to be more helpful. And hopefully they can make this more user friendly, or think about being able to utilize it in an easier way, or a more beneficial learning environment versus just having to memorize and take pictures and then do quiz parts. Okay, so do we want to do the cahoots? Do we want to do, there were a couple people saying cahoots, so do we want to do that?
Yes.
Yeah, okay, we can go to that. So I guess you guys do some thinking about it. If you want to kind of have me help you guys navigate through next week's sim chart, then just we can talk about that at the beginning of class next week after the quiz. Okay. Gosh, my computer is being so slow today. There is a helpful handout under the announcements. I don't know if you guys saw those for GIGU. Looking at that can be helpful too for you guys to look at. It's just under week 8 announcements. There's the handout that's blank, and then also the one with that has the answers there as well. Okay. It's taking forever to load. Okay. Okay, I'm sharing my screen here. Hopefully you can see that now. All right, go ahead and join me. Okay, I just need a couple more of you guys to join me. Okay. Good. Let's go ahead and get started here. So this is GI and GU. It's not separated, okay? Okay, multiple select. All of the following symptoms are symptoms of dehydration in an infant. Dry, pale skin, weakness and lethargy, loss of elasticity in the skin, increased urinary output. What are symptoms of dehydration? Yep, good. Dry, pale skin, weakness and lethargy, and loss of elasticity. Increased urinary output. What would it actually be if a kiddo's dehydrated? Decreased, right? Yep, good. What is the priority treatment for a child with dehydration due to profuse vomiting? Administer oral electrolyte solution, restrict PO fluids, maintain the child NPO, or IV fluids. What would you do if they're having profuse vomiting? Yep. So IV fluids. If it's profuse vomiting, that means that they're not keeping anything down, then they need IV fluids. If they're keeping some things down, then you can try and orally rehydrate them with an electrolyte solution like Pedialyte or Gatorade, things like that. Okay. We're not restricting oral fluid intake, even if we're giving them IV fluids to rehydrate them. You always want to try and encourage kiddos to drink if they will. Okay, good. Okay, what is the treatment for an infant with diarrhea lasting longer than 4 days? NPO, so nothing by mouth, water, Pedialyte, IV fluids. So, it's kind of tricky. So, because they're not vomiting, you can still continue to rehydrate them with oral fluids. If they're vomiting and they can't keep anything down and they're having diarrhea, then IV fluids will be your option. Okay. Okay, what acid-base imbalance may you see with a child who is having profuse diarrhea? Metabolic alkalosis, metabolic acidosis, hyperkalemia, or respiratory alkalosis? So metabolic acidosis, because your stool is alkaline. Okay, so if you're getting rid of a lot of stool, your body's going to be more acidic. Okay, and it's metabolic because it's your body, it's not your lungs. That's the difference between respiratory and metabolic. Okay, good. Okay, another multi-select. If an infant has not passed the meconium stool within the first 24 to 36 hours, what would you assess them for? Hypothyroidism, Hirschsprung's disease, cystic fibrosis, or electrolyte imbalance? Yep, good. Hypothyroidism, Hirschsprung's, and cystic fibrosis. An electrolyte imbalance wouldn't affect the meconium stool passage. Okay. Good. Deficiency of vitamin D causes what? Diarrhea, jaundice, rickets, scurvy. Rickets. Yep, good. So these kids are going to have poor growth, poor bone development. Okay. What else do you see with kids with rickets?
They have the bold legs.
Yep, good. That's exactly what I was looking for. Significant bowed legs that don't get better as they get older. Okay, good. Okay, multiple select. What treatment can the nurse anticipate for a child being unable to drink or eat anything with profuse vomiting and diarrhea? Sips of water, Pedialyte, a basic metabolic profile, and IV fluids. Okay. So profuse vomiting and diarrhea, they're going to need an IV fluids and a BMP. And that's the BMP, or the basic metabolic profile, that looks at, do you guys remember what it looks at?
The electrolytes.
Yeah, your electrolytes. So your sodium, your potassium, calcium, all of that. Okay, your glucose. Right? So you want to make sure that their blood sugar and everything's okay. Good. Okay, another multiple select. What nursing management would you anticipate for a child with a ruptured appendix post-operatively? So after they've had their repair. Complete bed rest, IV antibiotics, nasal gastric tube suction, and assess the surgical site. Yep. Okay. So why is complete bed rest incorrect? What happens if you have a kiddo who just had a belly surgery on complete bed rest? What may happen?
Aspiration pneumonia.
Yeah, like pneumonia from just being sedentary, right? Sitting there. They're going to also become more weak, right? So complete bed rest, not something that's required with kids after appendicitis. But because they were ruptured, they're going to be on IV antibiotics for a period of time. They're going to have an NG tube to suction. What is that supposed to do? What is that? What's the reasoning for the NG tube with suction?
I know one is to allow the bowels to rest and restore like motility, but
how about decompress the stomach? Right? Good. And then assessing the surgical site. Of course, they just had surgery, so that's going to be a really important part of your assessment. Looking at those incisions. You want to make sure you're, lifting their shirt up, looking under their shirt, assessing all of those sites. Okay, passage of urine, usually at night in children who should have voluntary bladder control. What is this called? Epispadias, vesicoureteral reflux, enuresis, or hypospadias? Enuresis. Okay, so that's having urinary accidents. Is enuresis. There is nocturnal specific enuresis, which is going to be just nighttime bedwetting. Okay, which can be somewhat normal in littler kids, right? Who are learning how to fully potty train. And then there's diurnal enuresis, which is daytime accidents. Okay, and remember with urinary accidents, if a kiddo has been totally potty trained and they start having either daytime or nighttime accidents, what should we be concerned about?
Is it a urinary tract infection?
Yep, perfect. Okay, another multiple select. What is Hirschsprung's disease? Congenital absence of the parasympathetic ganglion cells, ileus, congenital aganglionic megacolon, or enteric duplication cyst. So it's congenital absence of the parasympathetic ganglion cells. So the ganglion cells that are typically within the colon that give kids the sensation that they need to have a bowel movement, those are absent in kids with Hirschsprung's. Okay. And then they also have a ganglionotic megacolon. So their colon above, usually the lower portion above is enlarged. Okay. So they have both of those conditions with Hirschsprung. Usually it's caught pretty early because these kids usually have delayed passage of meconium, but sometimes older kids are diagnosed with Hirschsprung, like 3-4-year-olds. Okay, multiple select. When teaching parents about Hirschsprung's disease, the nurse would include what? Causes of bowel obstruction, requires a 2-stage surgery, infants or need for monitoring infants' bowel habits, or treating with laxatives and enemas. Yes, so it requires a 2-stage surgery. Usually, initially, it's them having a colonostomy or colostomy bag, okay? And then they remove that part of the colon that does not have the ganglion cells. And then they reastenomose, which means then they reattach the healthy colon to the portion that they made the colostomy bag. So the stoma for the ostomy, they reattach those two. And that's kind of the 2-stage. That's 2 stages of the surgery. Okay. Hirschsprung's also causes bowel obstructions. And then, of course, you're going to have to talk with parents about monitoring their bowel habits. Okay. Hirschsprung's you do not treat with laxatives or enemas because they do not have those ganglion cells that will alert their body to have the bowel movement anyways. Okay. Okay, what types of stool would an infant with Hirschsprung's disease have? Watery, no stools, ribbon-shaped stools, or hard stools? Ribbon-shaped stools, okay? For Hirschsprung's. Good. Which condition occurs mainly in children when the intestines telescope into itself? Paralytic ileus, volvulus, strangulation, intussusception. See how much you guys were paying attention because the answer was right there in the picture. So this is what intussusception, like if you did an ultrasound or an x-ray, you could actually kind of, or a CT, you could actually see this. So essentially the bowel tries to kind of go telescope or kind of back within itself. And you can reverse this by doing an air enema. A lot of times that's pretty successful. So essentially they just insert like what an air or an enema would be like and then inject some air and it will cause it to reverse itself a lot of times. Okay. How is somebody's stomach going to feel if they have intussusception? Like when you palpate it? Not sure. A lot of times you can feel kind of a bulge potentially in that area. Okay, multiple select. A 2-month infant has GERD, so acid reflux, okay? That has been treated by thickening formula. How do you know that this is working? The infant has a good appetite. The infant has less regurgitation. The infant is losing weight. The infant has appropriate weight gain. What is telling you that your thickened formula is being helpful? Yeah, so they're not vomiting. So they're not spitting up like they used to, and they're gaining weight. That's going to be how you tell that whatever you're doing for GERD, whether it's thickening formulas or doing antacid, so like omeprazole or something like that, that's going to be how you figure out if it's successful. Now, as far as the infant having a good appetite, even babies who have GERD usually still have pretty good appetites. Actually, they might seem like they're hungry nonstop. Okay. Good. How can you decrease the incidence of enterobasis in children? Give prophylactic antibiotics, treat outside areas with pesticides, keep fingernails cut short. After playing outside, have the child wash their hands, I think is what that is supposed to say, immediately after playing outside. Okay. So the best way is to make sure that their fingernails are cut short. Okay, do we all know what enterobasis is? Pinworms. Okay, so it's a parasitic kind of thing, parasite. Okay. If somebody in the family has pinworms, you should treat everybody in the family. Okay. And it's an anti-parasitic medication that they do. How do you find pinworms?
Is it place the tape over their bottom?
Yeah, over their rectum. Like over their anus. Mm-hmm. And then at bedtime, right? Yeah. Sometimes too, after this also sounds kind of crazy. The tape is crazy enough, but then sometimes some providers will encourage parents with a flashlight after their child's been asleep for a couple of hours to look at their bottom, and you can see usually then the parasites, hanging so they're little white worms on their bottom. So, okay. Something that happens, and usually they get it from outside, digging in the dirt, playing in the dirt, and then getting those little parasitic eggs under their long fingernails. And then, all kids always have their hands in their mouth. So that's kind of how they usually acquire. Okay. Okay. What are the signs and symptoms of enterobasis? Tense rectal itching, severe diarrhea, constipation, abdominal distension. Yes, intense rectal itching. They will not leave their poor bottoms alone. They're itching all the time. You hear the term ants in your pants. They're kind of wiggling all over. That's a lot of times what you see with kids with pinworms. Okay. GERD. What is GERD? Stomach contents backflow into the esophagus. difficulty or lack of defecation, an illness in which a person refuses to eat, or inflammation of the gallbladder. Yes, stomach contents that backflow up into the esophagus. Good. What would the nurse be looking for in a patient who has Meckel's diverticulum? Abdominal distension, large amount of flatulence, bruising, painless rectal bleeding. Yep, painless rectal bleeding is what you're going to see with Meckel's. Okay, good. Okay, a 6-year-old child goes to the ER due to abdominal pain, fever, vomiting for the last day. What's your assessment priority? When the vomiting started, description of the abdominal pain, vital signs, their last bowel movement. What's your priority? These are the questions we all have a hard time deciding what's the priority. Okay. So your description of your abdominal pain is your priority in this assessment. Why? What are you thinking is going on with this kid?
Appendicitis.
Appendicitis would be what you're most concerned about, probably, right? Because they're having a fever, they have abdominal pain, and they have vomiting. Okay. So you need to know where that belly pain is and what it feels like. Good. What would the nurses expect to see in an infant with biliary atresia? Excessive drooling that requires frequent suctioning, pale frothy stools and poor weight gain, poor tissue turgor and weight loss, clay colored stools and abdominal distension. Yep, they're going to have clay colored stools and belly distension with biliary atresia. Good. Okay, what structure of the mouth can be impacted by cleft lip and palate? Hard palate, soft palate, lip, or all of the above? Yep, it could be the hard palate, it can be the soft palate, or it could be the lip, or it could be all of them. Okay, so it just depends on the significance of their defect. Also, you guys know your uvula. You know what I'm talking about when I say uvula in the back of your throat. Some kids or people have what is called a bivid uvula. So that's when your uvula is split in half, or it has like, it looks like it's divided. And that can be a form of or a sign potentially of a cleft palate. Okay. So just for an interesting fact, I actually have a patient like that. That's pretty interesting. Okay. Cleft lip repair is typically done at what age? Between 2 and 3 months, at the same time as cleft palate, between 6 to 12 months, or between 2 to 3 years. Between 2 to 3 months. Why do you think that they do cleft lip repair pretty early on?
The suctioning or the sucking, being able to.
Yeah, to be able to eat, right? Yeah, good. When does cleft palate repair usually occur? 4 to 8 months of age, 12 to 16 months, 6 to 12 months, or 20 to 24 months. Yeah, so cleft palate is between 6 and 12 months. Okay. Usually. You're going to also see like cleft kids have like dental repairs, jaw surgery sometimes, depending on how significant their defects are. They'll have multiple stages of repair. Okay, esophageal atresia is what? Lack of an opening from the esophagus to the stomach at birth, new opening of the esophagus into the stomach, failure of the esophageal sphincter to relax, twisted veins around the esophagus. Yeah, lack of an opening between the esophagus and the stomach at birth. So what are these kids going to look like? They have esophageal atresia. What are you going to see on your exam? You think they're going to be fussy? Yeah. Probably pretty fussy because anything that they eat doesn't go to their stomach, right? So they're not getting that signal of being full. Do you think they're going to grow very well? No? What else?
Low weight.
Yeah, low weight. Yep, good. What about if their esophagus and their trachea attach? There's a little fistula there. What's that kid gonna look like? You think they're gonna breathe very well?
Cyanotic.
Yeah. Good. They're gonna kind of drown because whatever they ingest is going into their lungs, right? If they have tracheoesophageal atresia. Good. What are classic signs of esophageal atresia and tracheoesophageal fistula? So we kind of already talked about this. Okay, an olive-shaped mass in the right upper quadrant, visible peristalsis and vomiting, current jelly stools, failure to thrive, abdominal pain, bilious emesis, frequent stools, cyanosis, choking, coughing. Yep, good. They're going to be cyanotic, they're going to be choking, they're going to be coughing. Okay. If they have esophageal atresia or TEF or tracheoesophageal fistula. Okay. Good. So multiple select. Neonate with suspected tracheoesophageal fistula. Your nursing care should include what? Elevating the head of bed and NPO. Elevating the head of bed for feedings. Feeding glucose water only. IV fluids and antibiotics. Yep. These kids are going to be having their head of bed elevated. They're going to be not eating anything by mouth, IV fluids, and antibiotics because of the risk that potentially they've already tried to feed them, right? And they've aspirated into their lungs. Okay. Good. 5-year-old child is complaining of epigastric pain and persistent cough. What would you suspect? Gastric ulcer, gastroesophageal reflux, overeating, indigestion. Yep, good. You expect GERD. So if they have frequent cough and abdominal pain, especially if they tell you it's 30 minutes or so after they eat or after laying down, things like that. You definitely want to think about GERD. What is ranitidine used for in a child with peptic ulcer disease? Dries up stomach acid, neutralizes stomach acid, reduces gastric acid production, or fights stomach infection. Yeah, reduces gastric acid production. Okay, so it doesn't neutralize it, doesn't dry it up, just reduces the amount of gastric acid that's produced in the stomach. Thus, hopefully reducing the amount of ulcerations. Okay. Signs and symptom of hypertrophic pyloric stenosis. Okay, diarrhea following each feeding, olive-sized mass at the midline, gastric pain evidenced by vigorous crying, poor appetite due to poor sucking reflux. Yep. So olive-shaped and sized mass in the midline. So you're feeling their abdomen and you feel a hard olive-shaped mass kind of midline, on the stomach side at the base of the stomach. Then you would be concerned about pyloric stenosis. Okay. Signs and symptoms. What would you see with pyloric stenosis? Projectile vomiting, diarrhea, poor appetite, or both 1 and 3. So both projectile vomiting and poor appetite. Okay. So why is only projectile vomiting correct?
They still have the desire to eat.
They're not holding anything down. So they're starved, essentially. They're hungry all the time. They're also not going to be gaining weight well. Okay. And when we say projectile vomiting, when you're talking with parents, they'll talk about projectile vomiting all the time. And, maybe it was just more of a forceful vomit. But with pyloric stenosis, the projectile vomiting will truly be like the child sitting on the parent and, it could hit the wall back behind them. It's very forceful. Okay. Okay, preoperative treatment of pyloric stenosis includes what? Keeping the infant NPO and starting IV fluids. Start IV fluids. Infant can eat until about 2 hours before surgery or NPO after midnight. Yep, NPO and start fluids. Okay. Good. With kids, if they're NPO, essentially they're going to have fluids on them. I know with adults, a lot of times, they'll be NPO for surgery, and if they were admitted the night before, they won't always do fluids on them. But with kids, if they're NPO and they're in the hospital, they need fluids. Okay, what does celiac disease affect? Large intestine, small intestine, gallbladder, or pancreas? Small intestines, good. Also with the pyloric stenosis, the surgical repair, do you guys remember reading about what that was called? Okay, it's called a fundoplication. Okay, and once they have it's the name, the official name, the person who developed it was Nissen. So it's called a Nissen fundoplication. Probably remember reading about that. Once they have that, they can't vomit. Okay, they can no longer vomit. So that's kind of just something, you know, to know about. Okay, if you have celiac disease, what should you eliminate from your diet? Dark green vegetables, dairy, wheat, rye, barley, chocolate. Yep, wheat, rye, and barley. Okay. They can have dairy, they can have fruits and veggies, they can have chocolate. Okay. It's those grains, wheat, rye, and barley. Okay, priority nursing diagnosis for a child with ruptured appendicitis post-op. Pain medications, antibiotics, IV fluids, increased diet from clear to bland. Okay, yep, we're going to get IV antibiotics because they were ruptured, and all that ruptured, sick appendicitis fluid is in their belly. Good. Multiple select. How can you assess the effectiveness of fluid replacement for a child with severe dehydration? Heart rate, capillary refill, weight, blood pressure. Yep, all of those things. What's going to happen? Why would weight be an effective way? To check your fluid replacement?
I guess because once you're measuring like the I's and O's, you'll see if they're having any retention or something.
Yep, exactly. Good. Okay, multiple select. Vitamins that children with celiac disease are prone to lose are vitamin A, vitamin D, vitamin C, vitamin K. Okay, fat soluble vitamins. So that's vitamin A, vitamin D, and vitamin K. Okay, good. What foods would you select for a child with celiac disease? Bacon, omelet, banana, glass of milk, French toast, glass of water, fish sticks, macaroni and cheese, apple juice, roast beef, corn, and garlic bread. What could a kiddo with celiac disease eat? Yep, good. Banana omelet or bacon omelet, a banana, and a glass of milk. A banana omelet does not sound very appetizing. So none of that has grain or wheat or anything in it. Okay, what's phimosis? The opening of the foreskin is too tight. The foreskin is stuck in the pulled back position. The penis is stuck in an erect position, or increased urination. Yep, so the opening at the foreskin is too tight. Okay. Because that kids are more at risk for infections. What is a hydrocele? A normal swelling of the veins, sickle-shaped blood cells, collection of fluid around the testes, or inflammation of the epididymis. Yep, collection of fluid around the testicles. Okay. Okay, hypospadias is herniation into the urethra, an abnormality on the ventral side of the penis, an abnormality on the dorsal side of the penis, or an abnormality of the female genital tract. Yep, good. Ventral side. Hypospadias is the ventral side or the underside of the penis. Okay. Good. What is cryptorchidism? Testicular aplasia, testicular hypoplasia, failure or incomplete testicular descent, or malignant testicular neoplasm. Yep, failure or incomplete testicular descent. Good. You suspect an infant has cryptorchidism. How would you examine the infant? Have the child in a warm room for the exam. Hold the child upright. Cleanse the testicles with soap and water, or remove all clothes. Yep. They need to be in a warm exam room, right? For that testicle to want to kind of drop down into the scrotal sac. Okay. Good. Multiple select. How is hypospadias corrected? Foreskin is used to cover the ventral opening. A stent is placed in the urethra postoperatively. Correction is not possible. Surgery is done under local anesthesia. Yep, foreskin is used to cover that ventral opening, and then a stent is placed. So a little, whether they utilize a catheter as kind of the stent, but also then they a lot of times use a stent separate. Okay. And the surgery is done under general anesthesia, not local. Local would just be like they inject the penis with lidocaine or something and do the surgery that way. Okay. Okay, we'll do one more. What is bladder exstrophy? Midline closure defect. The bladder is left open and exposed outside of the abdomen. It occurs in the embryonic period of gestation, or all of the above. All of the above, okay? So like we talked about, it's very early on in fetal development. So it's within the embryonic period of gestation, remembering back to maternity. You guys can remember when that period all is, right? And then it's a midline closure defect, and the bladder is outside of the abdomen. Okay. Alrighty, let me quit sharing my screen. And we'll stop. Stop recording here. Okay, and then like I said,